Welcome to this peer voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/FAK. This activity is supported by an independent medical education grad from Madrigal Pharmaceuticals.
Hello, I'm Dr. Sven Franke from Antwerp University Hospital in Belgium, and I'm delighted to welcome Dr. José Luis Calleja from the Puerta de Hierro University Hospital in Spain. Today we're going to focus on the diagnosis, the assessment, and the treatment of MASH in the gastroenterology clinic. We have one treatment recently approved in Europe and another with a positive EMA opinion, making it imperative that we identify patients who might benefit from these medications. We're going to start with a look at why it's so important to intervene promptly in patients with MASH, and then we'll work through a patient case scenario, explaining the steps and factors to consider from first suspicion of disease through the treatment. So please, Dr. Calleja, start the conversation.
MASLD, it's very common, although is clearly underdiagnosed. In this meta-analysis, including more than 9 million people, the overall global prevalence in general population of MASLD is 30%, reaching in MASH 5% of the population. However, the numbers of diagnosed patients in primary care are clearly lower, as is shown in the slide, not reaching a prevalence of 3% in the best scenario. We know that progression is associated with poor outcomes. In this Swedish cohort of almost 500 patients with MASLD and paired biopsies, 30% of them progress over a median follow-up of 3.4 years. And which it's more important, those patients with progression have an increase in the incidence of end-stage liver disease, especially those with incident cirrhosis, as you can see in the slide. For this reason, it's very important to assess those patients who are at risk for MASLD. In this ESL guideline, as you can see in the slide, those patients with type 2 diabetes or obesity plus one cardiometabolic risk factor or persistently elevated liver enzyme need to assess the presence of MASLD. How can we assess this, the presence of this MASLD? Is using non-invasive methods. I think that we are going to discuss this non-invasive method using serological method and physical method to estimate the presence of MASLD. Before we move on the subject of treatment, please answer this challenge question.
So if we then look at potential treatment approaches for MASH, it's obvious that this disease is largely driven by dysfunctional adipose tissue and the metabolic syndrome as a whole. Lifestyle modification is key, so reducing caloric intake, improve the quality and the pattern of food intake, and physical activity are essential components to reduce body weight and sustain body weight reduction. You can improve MASH. You need about 5% to reduce steatosis. If you want to reverse steatohepatitis and especially have fibrosis reduction, you need about 7 to 10% weight loss, at least maintained weight loss. Professor Calleja, that sounds quite easy, but I think we know that in real practice, it's not always very successful, this approach. Can you share your experience and your recommendations on this?
my experience is very similar that is published in the literature, that approximately these aims of lose weight for 10%, it's only possible in 10% of our patients. So 90% of the patients do not achieve the enough weight reduction to achieve a fibrosis reduction or a steatosis reduction. So, in my opinion, we have to start obviously with lifestyle modifications, probably under the supervision of some specific professional, but always thinking in the majority of the patients, we are going to need some help, pharmacological help.
Yeah, I think I share your experience and recommendation, and it also means that we need also, obviously, other treatment options, pharmacological treatment options to treat MASH. There were very few options to date, and we have already about 2 decades of intensive research. We can, of course, use the GLP-1 receptor agonists in case of type 2 diabetes or obesity because that are the improved indications, and we had already some data that they might be efficacious for the treatment of MASH. But quite recently, the landscape has changed, and we have now 2 MASH-specific medications with EMA approval. So we have, first of all, resmetirom, which was based on a phase 3 trial, clearly efficacious in the treatment of patients with MASH and moderate to advanced fibrosis, so F2, F3. It's an oral thyroid hormone receptor beta agonist, and it got its European Commission marketing authorization already in August of last year. The second drug with positive phase 3 data in patients with MASH and moderate to advanced fibrosis, so again F2, F3, is semaglutide, the injectable GLP-1 receptor agonist that recently received a positive opinion by the European Medicine Agency. For both drugs, that marketing authorization is of course conditional. It's based on surrogate endpoints, so we still need to see the clinical outcomes on the long run to get definitive approval. Now, if we take a little bit a deeper dive into the results of those 2 drugs. So first of all, you have the MAESTRO-NASH phase 3 trial of resmetirom. You see here the main results on the primary endpoints. There's MASH resolution with a clear benefit of the drug over placebo, but also fibrosis improvement of at least 1 stage without worsening of MASLD activity, with a clear benefit from the drug compared to placebo, with an effect size of about 12% for the resmetirom 100 milligram. In relation to the mode of action of the drug, it also reduces LDL cholesterol level, which might be also beneficial on the long run in terms of cardiovascular disease, but of course that remains to be proven. In terms of safety and tolerability, the drug was well tolerated. There were some side effects, numerically more in those with active drug compared to placebo, mainly diarrhea and nausea, but no signs or signals in terms of serious adverse events or reverse events that led to discontinuation of the drug. So it's that combination of efficacy with safety and tolerability profile that has led to FDA and EMA approval. Also important, real life, there's already GLP-1 receptor agonist treatment for diabetes, for obesity. In the MAESTRO-NASH trial, we looked at the potential impact of that on the treatment response, so comparing patients with background GLP-1 receptor agonist therapy for diabetes or the absence thereof. And as you can see, both for the MASH resolution and the fibrosis improvement endpoint, both those groups, whether being on a GLP-1 receptor agonist or not, showed similar trends in terms of response. So basically, that background therapy did not have an impact on the response rate. So we do now have 2 drugs with proven efficacy in phase 3. and with FDA and EMA approval, not yet available or reimbursed everywhere. So we have to see how that will evolve in terms of availability over the next month. But at least we do have now some treatment options. And I also thank Dr. Calleja for the nice conversation we had about this topic before taking a deeper dive into several aspects. But before we do that and go into the case scenario, please answer this challenge question.
Welcome back. We are going to discuss this clinical case, which is very similar to one that you can find in your clinic every day. And we are going to discuss with Dr. Frank this case from this initial stage to the final step of treatment. So this is a female of 52 years old with a BMI of 28 that is seen in the gastro clinic for inflammatory bowel disease, especially and specifically an ulcerative colitis. She's also a type 2 diabetes person that is well controlled with metformin plus a DPP4 inhibitor, and she's also hypertension with a control hypertension. In the blood samples, you can see an AST of 68 and ALT of 96 that are slightly elevated. Also an LDL cholesterol of 4.4 millimoles, and also a triglyceride of 2.4 millimoles per liter. So in these patients, there is different risk factors that clearly increase the risk of MASLD. As you already know, the prevalence of MASLD in the overweight or obesity population is clearly increased. It is also MASLD much more common in patients with type 2 diabetes, especially in those that are over 50, as is the case in our patient. And which is more important, the prevalence of clinically significant fibrosis in this diabetes population is clearly increased. MASLD is also increased in the postmenopause women, and also it's increased in those patients with an inflammatory disease, specifically in those with inflammatory bowel disease. So we have this patient with at least 3 different risk factors. She's a female diabetes patient. She's a hypertensive patient, and she has an elevated enzymes and a cholesterol increase in the blood sample. So this lady has different risk factor to have MASLD. Now, please answer this challenge question. Thank you. Now, I will hand over Dr. Frank to talk about the FIB-4 test.
Let's have a look again at our case. The lady of 52 years old with overweight seen for ulcerative colitis. She also has a metabolic profile, not just the overweight, but also the arterial hypertension and the diabetes. And she has those chronically elevated liver enzymes. So now several questions here. First of all, of course, we have to get an idea about the underlying cause of those chronically elevated liver enzymes, because it's not because she has risk factors for MASLD, MASH, that's the only explanation. That is something we have to take into account. But the second question is also, when we think about treatment, is to have an idea about the stage of fibrosis, because fibrosis in the end will determine the long-term prognosis of the patient. So assessing fibrosis and the presence of advanced fibrosis is a very important one. And the first step to assess that question in all the guidelines is the calculation of the FIB-4. I will discuss in a moment what it contains, but it's just 4 parameters where you can easily calculate the value. And if the value is low, below 1.3, the negative predictive value is high, so you can be quite sure that there is no advanced fibrosis, because that's the target of the fibrosis screening with FIB4. It's the advanced fibrosis, so mainly F3 fibrosis, not necessarily F2. When the value is more elevated than that, you have 2 different scenarios. The most or the bulk of the evidence then tells you that if it's above, then you need a hepatology referral. Now, when we discussed the EASL guidelines, we adopted a more pragmatic approach because as was illustrated by Dr. Calleja in the introduction, about 30% of the adult population has MASLD, so it's a huge number of patients that need to be screened in first line or in second line. So the pragmatic approach is to work with a double threshold, and there's also a high threshold of 2.67, and if you are above, then there is a clear indication that there might be advanced fibrosis. Positive predictive value is far from being perfect, so there you would need a second line test. But if you are in the intermediate zone, you have 2 options, or you can go straight away to the same option as with the high value, you go to a second line test. Or if there is room for improvement on the metabolic drivers of disease, you can first intensify those treatments, try to improve the metabolic drivers of disease, and then re-evaluate after 6 months or 1 year. And if there is a clear improvement of the FIB4 to a value below the 1.3 threshold, then you still have to follow up the patient, but at that time you can reassure the patient that you have very little arguments for advanced fibrosis. If it remains in the gray zone or it evolves to a high value, then again you have to go for a second line test. Now, FIB4 contains 4 parameters, as the name suggests, and these parameters are easily available. It's AST and ALT, so the 2 transaminases, its platelet count, and its age. Now, age is, of course, part of the calculation, which has an impact on the value. And the consequences are that below the age of 35, unfortunately, FIB4 is not reliable. So at the younger age, you cannot use FIB4. If it's above 65, you need adapted cutoffs, especially for the lower cutoff, which is then not 1.3, but 2.1. And that is, as I said, if you work with a double threshold approach. With those considerations taken in mind, the accuracy, especially as a first screening step to exclude advanced fibrosis, the accuracy is quite acceptable. And there's an online calculator. You can find it in the EASL guidelines app, but there are also other apps available. In this app, you can also find other very interesting information to guide you through the management of patients with MASLD, but that's how you can use it in clinical practice. If we apply it now to our patient, what we need as additional information is obviously the platelet count, which is 141, and it gives you a FIB4 value of 2.56, which then comes with the question what to do with this value. So before we go on, I invite you to answer this challenge question. Thank you. And next, Dr. Calleja will discuss vibration control transient elastography.
So after this FIB4 calculation, with a value of 2.56, we are in the intermediate range, and we need further testing to confirm the presence of steatosis and especially refine the assessment of fibrosis. If we look to the algorithm, the second step is to use other technology like vibration control transient elastography or other alternative tests. In my practical point of view, I only intensify management of comorbidity if the patient is very uncontrolled, which is not the case that we are reviewing. This patient, I have to make a remind that is a patient with a good control type 2 diabetes and also a good control hypertension. So probably in our case, we go directly, as we do in the majority of our patients, to a second test to refine the assessment of fibrosis. And if we follow this algorithm of the ESEL, we use vibration control transient elastography, which is a technology that assesses the state of the liver, evaluating the elasticity of the tissue. And we know from different trials and studies that if you have below 8 kilopascals, you have a low risk of advanced fibrosis. And in the other hand, if you have more than 12 kilopascals, you are in a high risk of have an advanced fibrosis. In the same measurement, you can also evaluate the stage of steatosis with the CAP technology, which evaluate the ultrasound velocity in the liver. And you can see in the slide the different cutoff to graduate the steatosis. Between S1, if you have more than 248 dB, or S3 if you have more than 280. The liver elastography with the FIB-4 in the assessment of the liver-related events are very accurate, as is shown in this slide. The accuracy of histopathology in comparison with the BCTE were not significantly different. So this non-invasive method to assess the prognosis of the patient, it's very accurate. In our case, the BCTE was 11.3 kilopascals and the CAP was 271 dB. So we need in this patient, due to the close value to the threshold of 12 kilopascals, to rule out the presence of cirrhosis before making further decisions. Now, please answer this challenge question. Thank you. Next, Dr. Frank will discuss the other non-invasive tools that you can use to assess suspected MASH.
If we consider again our case, we have now more information. We also not only know that the FIB-4 is in the intermediate zone, suggesting the presence of fibrosis, but also there is an elevated liver stiffness. And so in this patient who is otherwise quite well controlled for the metabolic comorbidities, the question arises if this is a patient eligible for a liver-specific, MASH-specific treatment on the one hand, and can we reliably exclude cirrhosis on the other hand? Because that's also a key question, because the drugs that are currently approved for MASH are not approved for patients with cirrhosis. So this is a very important question. We already discussed, or Professor Calleja discussed, the position of liver stiffness and how to use that. If we use FIB-4 as a first line, it can be considered a second line, but in a gastroenterology setting, FIB-4 is just a little bit of screening test sometimes, and you need sometimes more confirmatory tests to really select the right patients for pharmacological therapy. And as stated in the EASL guidelines, there are alternative tests beyond liver stiffness measurement by VCTE that can be used, such as the ELF score or the magnetic resonance elastography as examples. Now, The ELF test is an important one. It's a blood-based test with 3 parameters. It's hyaluronic acids, it's procollagen 3, and terminal peptide, and TIMP1, reflective of fibrosis, but also of ongoing underlying steatohepatitis that drives fibrosis. That's an important one. And as I said previously, it's important to identify MASH with fibrosis, but also to exclude cirrhosis because the drugs are not indicated in patients with cirrhosis. Thresholds that we use to exclude cirrhosis are the 20 kilopascals for VCTE, 5 kilopascals for magnetic resonance elastography that I mentioned, and then the ELF test, there the upper threshold for the diagnosis of fibrosis is 11.3. The 20 kilopascals for VCTE are an important one, although if I refer to the Baveno guidelines and the rule of 5, already from 15 kilopascals on, we can assume that it's compensated advanced chronic liver disease, so being close to cirrhosis, and especially in the category between 15 and 20, we need additional confirmatory or exclusionary tests, and there a test like ELF could be very helpful to have a more reliable diagnosis of cirrhosis or exclusion of cirrhosis on the other hand. This is also reflected in the guidance that colleagues from the ASLD issued to guide ASLD physicians for the use of resmetirom. Again, on the green light is when you have the values that are suggestive of MASH with fibrosis but exclude cirrhosis. A red light comes when you have those thresholds for cirrhosis that I previously mentioned. And if you are in between, then of course you need additional testing to make sure that you can reliably exclude cirrhosis. So for example, if you have a VCTE value of 17, then probably an ELF test can be helpful as a second-line test to reinforce the diagnosis of advanced fibrosis and exclude cirrhosis to make sure that you are treating the right patients and not treating patients that do not respond to the in and exclusion criteria for such treatment. Specifically in our patient, the ELF test was 9.4, which is below the 11.3 threshold. So here, together with the VCTE of 11.3, I think we have probably enough arguments to exclude cirrhosis, but to say that the patient has steatohepatitis with fibrosis and hence might be eligible for pharmacological treatment. So please answer now this challenge question. Thank you. And next, Dr. Calleja will look at the latest treatments and when to use them.
So in this case that we are presenting, we have this lady with a FIB4 value of 2.56, which is an intermediate value, with a VCTE of 11 kilopascals, which it's mainly it's like an F2, F3 patient with an ELF of 9.4 and is rule out the presence of fibrosis. So when we have to think about the approach to this patient, we have two different options. We have a liver target option and also a metabolic approach. Resmetirom, as you can see in the slide, and has been explained elegantly in the introduction by Dr. Frank, is an agonist of the thyroid beta receptor in the liver, provoking a improve in the lipid profile and also a reduction in the oxidative stress, inflammation, lipotoxicity, and also improving the fibrosis. On the other hand, we have the semaglutide. We know that there is no GLP-1 receptor in the livers, but we know that have a very good effect in weight reduction, in reducing metabolic dysfunction, also reduce inflammation and lipogenesis, and it's act down-regulating fibrosis-related genes. And we know that this has an impact in the fibrosis regression. So in our patient, we have these two different options. In this type 2 diabetes patient that is well controlled on metformin, and she has also a controlled hypertension, we really can favor the use of a liver target option. If this same patient has an uncontrolled diabetes, I will also add the presence of GLP-1 agonist like semaglutide. Dr. Frank showed in the introduction that in the MAESTRO trial, the effect of resmetirom was similar in those patients that were receiving GLP-1 agonist due to diabetes control or for the diabetes control. Also, we have to speak and to talk with the patient regarding the preference of receiving an oral treatment or a weekly injectable treatment. Now, please answer this challenge question. Thank you. Next, Dr. Frank will discuss treatment, monitoring, and when to refer this patient.
So remember again the case, our lady of 52 years old, slightly overweight, well-controlled diabetes and metabolic syndrome, elevated liver enzymes, suggestive of MASH, with also the indicators that we discussed about the presence of fibrosis, but excluding cirrhosis. So a patient clearly with lifestyle modification already more or less optimized, given also the well-controlled diabetes and the other parameters that were well controlled, still having MASH and fibrosis, so an indication for pharmacological therapy. And in this case, the patient was put on resmetirom. However, we have, of course, to follow up the patient also to see whether the treatment is efficacious. And although we do not have very clear guidance on how to define response based on non-invasive tests, we can have an indication if we follow transaminases, if we follow liver stiffness, if we follow ELF over time. Now, in this patient, there's a new development. The patient reports upper left abdominal pain. There's an ultrasound done, and it confirms splenomegaly, which is a little bit cumbersome because if you remember, the platelets were already a little bit low with 141 at the border of what you would expect when patients evolve to cirrhosis. And the other tests were not indicative of cirrhosis, but with the evolution over time and the appearance of splenomegaly, you should consider at least the possibility of cirrhosis. So I think this patient really needs to be seen by a liver specialist to do further investigations about the potential presence of cirrhosis and to discuss some other treatment opportunities, which might be the involvement in a clinical trial, for example, or surgery or some other options that might be there. But I think clearly this needs a further workup. The case we just presented clearly illustrates that MESLD MASH is not an isolated liver disease, but is part of a systemic disease that really needs a broad, comprehensive approach. And that's why with EASL, we undertook an effort to bring together many stakeholders around the patient with MESLD MASH to design the SLD patient trajectory, where we discuss at any stage of the disease who can do what and how should we collaborate with each other to improve ultimately the care of the patients with MESLD. So we need to collaborate with first-line colleagues to support us in good screening, but also in the lifestyle modification with dietitians, physical activity trainers, and other healthcare providers that can support us in that endeavor. We need to collaborate with other colleagues that treat components of the metabolic syndrome, the diabetologists, endocrinologists, cardiologists, obesity physicians, and a whole range of other specialty colleagues that might be involved. And we have to position ourselves also towards the referral to more expert centers in hepatology when the case deteriorates and we have indications of progressive disease or non-response to our treatment options. So with this in mind, you can now answer this final challenge question. And I thank you for watching.
This has been an activity published by PeerVoice.